Okay, so welcome back. This week we are following up with disorders of our fluid and electrolytes. One of the main things we think about when we talk about fluid is water and the body's movement of water. If we have too much fluid in one area or interstitial space from some reason, that's going to cause edema or swelling. So accumulation of fluid in the interstitial spaces or too much expansion of fluid in those areas is going to lead to swelling of that area, like a leg or an arm. It's more a problem of fluid distribution. It doesn't necessarily mean that we have too much fluid in the body or water in the body. It just means that it's in the wrong area. Edema can be caused by 4 different things: an increase in capillary pressure, a decrease in capillary colloid osmotic pressure, increase in capillary permeability or an obstruction to our lymphatic flow or lymph flow in the body. We're going to look at each of these a little more closely so I can explain them for you. So an increase in capillary hydrostatic pressure is whenever we have too much pressure put on a capillary or a vessel, and it is going to essentially cause increased pressure in that vessel, so then it's going to stretch the walls and have leaking of the fluid out into the tissues. This can be from venous obstruction, right, where it literally pushes fluid from the capillary into the interstitial spaces. Causes of venous obstruction can be things like thrombophlebitis, liver or hepatic obstruction, tight clothing around the extremities, or even prolonged standing, where you'll see swelling in the feet and legs. Certain conditions like heart failure and renal failure can also relate to this problem with edema. They do that by changing our salt and water retention methods. Alright, if we have too much salt accumulation, it throws off our sodium and water balance, and renal and heart failure can do this. We can also have edema because of decreased capillary colloid osmotic pressure. So osmotic pressure is essentially our concentration of stuff in a fluid. And when we're talking about blood and body fluid, our biggest stuff that we're worried about is our plasma protein. So if we don't have enough plasma protein levels in our circulation, then it's going to cause shifts of our fluid. Alright, low plasma protein levels causes a decrease in oncotic pressure, which means that the capillaries in the fluid is going to move into the interstitial space because it's going to shift depending on the gradient of concentrations, kind of like you learned about in chemistry. Right, when it shifts out of our vessels and into our interstitial spaces, then we get edema. This can be caused by diseases of the kidneys, if we have a lot of drainage, serious drainage of open wounds, bleeding, which is excessive, or hemorrhage, which is excessive bleeding, burns, or cirrhosis of the liver, because liver helps us to make our plasma proteins. The third problem that can cause edema would be an increased capillary permeability. So permeability, we said before, is related to how easily things move in and out of a membrane. Alright, so we're saying it's increased in our capillaries, which means it's increased, it's more permeable, it's easier for fluids to leak out. What happens then is that proteins escape from the blood vessels, get into the interstitial tissues. This causes a decrease in our capillary oncotic pressure and an increase in the interstitial fluid protein. So the fluid or water is going to follow the protein, and then we end up with edema in our tissues. This can be caused by conditions like the inflammatory or immune responses that happen within the body, burns or crush injuries, neoplastic disease, or an allergic reaction. The last cause of edema would be lymphatic obstruction. Right, this has to do with your lymphatic system. Right, it results because there's too much accumulation of proteins and fluid in the interstitial space. All right, and that leads to lymphedema. This can happen whenever we have damages to any of our lymphatic vessels or lymph nodes, usually because of inflammation, tumors, or surgery. So the lymphatic fluid cannot drain properly through the body and through its system, so then it just accumulates in the tissue and causes swelling. So edema can be localized or generalized, meaning it can be in one area or it can be systemic and throughout the body. Right? Localized edema is usually caused by trauma. All right, you hit your arm, you swell at the site. You hit your foot, you swell at the site. All right. Generalized edema can be caused by a variety of different things like inflammation, swelling. All right, it's the uniform distribution of fluid in various interstitial spaces. All right, the location usually is what signals how severe edema is. So localized edema of the finger, okay, it stinks, but it's not a big deal. Localized edema of our brain, like in these scans shown on the right, big deal. All right, brain doesn't like swelling at all. All right, same as if we have it in our lungs or our airway. All right, so here are some different pictures. The legs on the left here, this is images of lymphedema. So she has an obstruction here of our lymphatic system in that leg. So lymph fluid is accumulating and causing swelling. This is localized swelling of the larynx, and there's your vocal cords. All right, so obviously this person's probably having difficulty breathing. This individual has periorbital edema around the eye. Right, and this individual was in a trauma and has cranial edema around his facial features. All right, so we need to assess fluid status. Right, this can be the accumulation of fluid in our tissues. One of the easiest ways we can do is visual assessment, right? It's pretty easy to compare one side to the other to see that we have edema occurring, right? We can also weigh someone, especially if we're worried about generalized edema all over, right? They would want to advise the patient to weigh themselves at the same time in roughly the same amount of clothing on the same scale each day to give us the most accurate measurement. And we track their weight. So if they have 1 extra liter of fluid, that's equal to 1 kilogram, also known as 2.2 pounds. All right, so for instance, if someone has a weight gain of 2 pounds, roughly, we know they're carrying a significant amount of extra fluid. All right, 4 pounds, 4.5 pounds is about the size of a 2 liter of fluid. Right. We can measure the area, taking a circumference or a girth around it. We can also look for pitting edema. That's where we press down on an affected area and lift our finger up, right? And then we rate it by how deep the indentation is left behind. Shallow would be +4. As it goes deeper, it can get rated up to +4. Or I'm sorry, shallow is +1. As it gets deeper, we can rate it up to +4 pitting edema. Right. To treat fluid volume issues, right, it's going to depend on the cause. So we have to go back to those 4 things that can cause edema. We'll treat edema caused by lymphatic obstruction much differently than we'll treat it by lack of plasma proteins. Right. Some general things that help pretty much all kinds, right? Elevation of the extremity, using support hose, right? We can also give diuretics to pull off extra fluid, albumin to help correct any imbalances in our plasma protein, and if they're caused by some type of clot or obstruction, to remove it. We also have hormones that help us to regulate our fluid balance. Our biggest one is ADH, also known as anti-diuretic hormone. So think about the name. Anti means against, diuretic means to get rid of fluid, or peeing usually. So this hormone literally is against peeing, right? So that's how it helps us to hold on to our fluid if we need it. It activates different parts of the kidney, right, to help us do that. It's produced by the hypothalamus and gets stored and released by the posterior pituitary gland in the brain. It regulates fluid retention or water retention by decreasing diuresis or pee formation in the kidneys, right, to increase the amount of fluid that we keep within our body. Water is then reabsorbed in the tubules and not released in urine so that we can keep using it. Right, an increase in serum osmolality or concentration of our blood serum, or a decrease in blood volume, is going to stimulate ADH to be released, because these are things that signal that our body is dry and needs extra fluid. If we have a decrease in osmolality or an increase in fluid or blood volume, then it's going to inhibit the release of ADH, right? So that's the opposite. This causes less water to be reabsorbed and makes urine less concentrated. Right. There's 2 problems that we have related to ADH. All right, there's syndrome of inappropriate antidiuretic hormone. That's when we have too much ADH in our body. And then there's diabetes insipidus, where we don't have enough ADH. Alright, diabetes insipidus has nothing to do with blood sugar. Alright, so don't confuse it with diabetes that most of us think of commonly. Alright, it has to do only with ADH. Alright, so let's look at antidiuretic hormone in SIADH. Alright, so in SIADH, we have an overproduction of ADH. Something is making an extra release of this hormone despite the fact that we have enough fluid volume going on in our body. Alright, so then what happens is we hold on to every amount of fluid that we can, even though we don't need it. Alright, that makes our serum diluted, or hypoosmolality. Alright, it dilutes out our nutrients and our electrolytes like sodium and causes dilutional hyponatremia. It's similar if you think about an example like Kool-Aid. Right, if you have a picture of red Kool-Aid and it's only half full, if I dilute it by dumping in more water but no Kool-Aid, I end up with light pink Kool-Aid. Okay, light pink Kool-Aid because we diluted out the red food coloring in the red Kool-Aid, alright, and it's turned pink. Same thing happens in our blood and serums with dilutional hyponatremia here. Alright, the urine's going to be concentrated because they're not making much of it. Alright, they have low urine output. Their body weight's going to go up because they're going to be holding on to those extra liters of fluid, so the pounds keep going up. Alright, sodium levels can fall below 120, and that can cause complications like brain swelling, which is cerebral edema, and seizures. This can be caused because of malignancies like small cell lung cancer, head traumas, or medications. So when you see SIADH, I want you to think that they're holding on to water. Alright, so to treat it, we need to figure out the underlying cause and restore it. Alright, restore normal fluid volumes and restrict fluids intake, alright, drinking and IV fluids. You'll probably need diuresis through diuretic medications. We'll give hypertonic solutions, alright, when we have to treat sodium levels and bring it up slowly to normal so we don't cause seizure and complications. Diabetes insipidus is the opposite problem. Alright, so they're going to have an underproduction or undersecretion of ADH. This is characterized by excessive, huge amounts of increased urine output that's very clear and dilute. Alright, that's how it gets its name for diabetes. Diabetes means excessive urination. Alright, this urine is so much and so clear that it almost looks like they're peeing just gallons of water. Right? They can have increased plasma osmolality because it's going to be very concentrated. These people are excessively thirsty. That's known as polydipsia because they're trying to correct their fluid imbalance. Right? They can have high sodium levels and hypernatremia, and they're very concentrated serum levels, so that's elevated serum osmolality. They can pee anywhere from 5 to 20 liters of urine a day, so that's about 2 liters of urine output each day. Right, and that can cause excessive dehydration. Right, it can be caused by head trauma, lesions to the hypothalamus, complications from drugs such as lithium and dilantin, intracranial surgery. Right, it can be nephrogenic, which means it's a problem that started in the kidneys, or it can be central, which means it's a problem related to the brain. To treat it, we need to figure out what the cause is and correct that. Right, we need to maintain normal fluid and electrolyte imbalance through IV fluid administration. We can give them synthetic or man-made ADH. These are medications like vasopressin or desmopressin. Right, we would limit their sodium intake, right, because they're already got high sodium levels. We don't want to make them have complications related to hypernatremia. We can also give them thiazide diuretics to help them as well. Right, this is just a little table that shows you comparing and contrasting diabetes insipidus versus SIADH. Remember, they are opposites of each other. This is just an infographic if you're someone who likes visual examples between SIADH where you have too much fluid in the side effects, or diabetes insipidus where you have not enough. Next up, we will talk about electrolyte imbalances, and you can pick up with that in the next video.